So, it was challenging. We've had some fantastic discussions. And there was a while where I thought, I'm never going to be able to put this together. But actually, as the day went on, I think a lot of themes did start to come out. We started to come back to things, and you could hear the same sentiment expressed different ways. So we're going to move to our panel discussion now in a few minutes. So I'm just going to recap for us on what kind of things we've been talking about to jog your memories, so that when we bring our panel up here, that we'll see there's some areas now that we have a last chance to explore a little bit more. And I think it's a great time. I know it's a long day and I really appreciate everyone sticking with us, but it's a great time now that we've really thought about it, and we've had such great input from so many viewpoints that's really made it much richer to start to try to take it forward. So this morning, Karen spoke to us about advanced care planning and advanced directives, and instantly in that discussion people felt we needed to know a lot more, that rather than jumping into trials, that really palliative care and dementia, because there isn't enough information out there, we need to be doing a lot more observational studies and finding out a lot more before we even try to think that we have a solution. And some of the comments we got from people were, not to forget quality improvement projects and not to forget some small and pilot studies, that it doesn't have to be a mega study, that a lot of small studies, when we add them together, can help a lot. And one of the questions that was asked about advanced care planning or advanced health directives was outcome. Can we show the outcome of them? We had a bit of a discussion about longitudinal studies and how maybe they're not going to be feasible for this. And we didn't really get to how else. We talked about there might be other ways of capturing the benefit, if there's a benefit of advanced care planning, but how might we do that? So that was something that maybe we might think about coming back to. How do we prove or explore the benefit of advanced care planning, or specifically advanced health directives? And then another thing was the timing of who is the person that should be starting this conversation and when. And again, a comment came about, the fact that it really should be started early and in the community. So we got to a certain point in our discussions about advanced care planning, and I think it triggered a lot of thought, but clearly more to discuss. Our next talk then was Joe Eustace, coming at it very much from a methodology point of view. So dementia is not his area, palliative care is not his area, but he is a very good methodologist, and he really put it up to us. What are we looking to do? And very clearly very early on what came out was that we need validated outcome scales for palliative care and dementia, and they are not available at the moment. And then straight away that got us into the whole idea of how do we include people with more advanced dementia. Sorry about that, I just touched something. Is it B to blanket? Or not? How do we include people with more advanced dementia where they may not be able to tell us, self-report symptoms? And we got into great discussions about potentially IT. Is IT the solution? That we can hook somebody up to monitors and unobtrusively see some physiological markers of distress or other markers of distress. And we talked about how certainly in maybe residential care that there would be an economy of scale of doing it, maybe not going out into people's houses over a 30-mile radius. So you have to think about your setting. And then we also talked about, let's not think that the person with advanced dementia we can't still communicate with them and have information. So we spoke a lot about a person's ability to communicate right to the end, and how we need to be inventive and how we can facilitate including a person with advanced dementia. And again, comments came out again and again about the lived experience, and that we need a lot more information about the experience of the person with dementia, and that we need to be innovative in how we can capture that better. We talked about patient and our public participation in research, that we don't want it just to be a tick box exercise, we want something actionable. Joe told us how this would be really suitable for this thing of a SWOT, a study within a trial, that you could actually look at, when you say you're engaging users and public, actually how effectively are you doing that, and how much are they actually changing the intervention as opposed to just being a research subject. And we talked about the multiple viewpoints, and this has come again and again. You know, it's not just the person, it's also their carer. It's not just one carer, it's multiple carers. And we had this lovely concept of the actively interfering relative. You know, and again, is that an area that we need to look at, is interface with carers. And then we moved on to Kate, particularly talking about person-centred care. And again, we talked about the broad range of disciplines that need to be involved to really fully understand the experience and the symptoms, therefore, that we think a person with dementia will have, particularly in advanced disease. We talked about things like incentivizing nurses or GPs. We got a few comments. People didn't like the idea of having to incentivize people. Is that really a good way to change practice? We talked about job satisfaction. And we talked really about that, you know, policy, the glossy brochure is no good. It has to be action that we're looking for. A little bit of talking about, you know, staff really not looking as if they have been adequately trained. Both doctors and nurses came under criticism. Some people felt uncomfortable with that. We got some comments back. But again, this is all about, by looking at a huge range of perspectives, we start to really come better to the overall truth. And so we could tell that we were starting to get close to things that were a bit uncomfortable for some of us, but that's all part of trying to understand better so that we can better perform research when we're doing it. So then we had George Kernahan looking at kind of particular focus on symptoms, and one of the things came out, which is the best setting to be looking at doing research in. And then we talked, I suppose it was me had introduced this idea of a care bundle, a flash of inspiration. I'd never thought about a care bundle for palliative care in dementia. And a lot of people right back at me are, you know, you have a care bundle as one way to go, but what about education? What about educating people better? But then if you do that, how do you sustain it? Because we know education works for a while and then everything falls away. Or how about knowing the person? You know, that if staff truly know the person, then you would need a care bundle. And, you know, straight away I got thinking, oh my, you know, wouldn't that be lovely? Look at which is best, or how can we get more information about which might be more suitable? And then we moved on to a concept of, well, let's stop looking at what's wrong and approaching it from a negative point of view. Let's look at the features of excellent care, and can we look at a model of excellent care and pick it apart and tell what could we start to incorporate. And then we had a model of excellent care, and I'm, you know, straight away thinking, well, you know, the Oxley's example, is that something that would be feasible, or could we look at elements and see, could you or couldn't you implement something like that in an Irish healthcare setting? And another thing that came up was the issue of chemical restraints, and again, a few people really vocal about that, and Kieran had mentioned the PhD that he's doing on looking at why are people prescribed antipsychotics, because unless we understand what is motivating the prescription of antipsychotics, if we think they're not appropriate, it's very hard to solve the problem, so that might lead on to more. And then so Adrian gave us the fantastic example of their service, and that really got us talking about this need for integration between palliative care and dementia care. And again, there's great opportunities there to look at, you know, how can we actually practically do that? It's great to say, yeah, we'll all work together, but actually how might that take place, and what would be the facilitators and barriers of that? And then we talked about care across sectors, so it's not just between different disciplines, but it's actually between the community and residential care, and that's again another area that we could look at. How do we get ourselves to integrate across sectors? So organisation of care, access to specialist services, all of that came out as really potentially fruitful areas for research. Another little thing that came out was this idea of transferring to die at home. So somebody maybe who is in residential care actually transferring home, and the idea of, you know, can we accept more risk? Because after all, we've identified that somebody's actively dying. And I would say in Ireland, can we provide for their care needs if we do that? And then we came on to the concept of GPs and public health nurses and this kind of primary care, palliative care in the area of dementia. And then finally, I think David really summed together a lot of what I think some of what we'd been talking about and the European perspective on it, you know, and certainly again what really struck me was the recognition of need, this whole idea of recognising the need. If you don't recognise the need, then you don't try to improve things, and this whole idea of collaboration across services. And obviously I'm sure a lot of you are saying, but you never mentioned such and such, and of course we all take different things out of it. This is what three of us together kind of seem to come up with. And so we're going to move to a panel discussion. So I'm going to ask the panel members to come up. So as she frantically looks. So Professor Brian Lawler, Psychiatry of Old Age, Dr. Suzanne Guerin from UCD, who researches a lot in palliative care, and Dr. Joan McCarthy from UCC, ethicist extraordinaire. And also we were going to ask David Oliver to rejoin. And am I right? Am I missing? And Adrian. Yes, thanks. To rejoin. So we're doing well. We had said we'd be finished by 5, and I think we will be well wrapped up by 5. I really do appreciate people staying on to the end, but I think this is a really useful time to try to move to the next level. So I've kind of summarised for you. Feel free to talk about something that I haven't mentioned there at all. So I wonder, does somebody want to kick off the discussion? And I'm going to step away at this point, and I'm going to, thankfully, I'm getting Sean to chair this part. Where do you want to start?
So I don't know, do any of the panel wish to kick off the proceeding? Yeah, go ahead.
I want to say something. It's been sort of at the back of my mind for the day, so I thought I'll just say it and then it'll be said. About advanced care planning, I just want to say something that I think is important about it in relation to people with dementia. The first is that it's important to distinguish what is advanced care planning from advanced directives. And we won't go into that for now, but one thing I want to say about advanced directives, specifically in relation to people with dementia, we talked earlier, and I love that graph where you see the person with the cancer trajectory and they go like this and then they drop off. The person with dementia is much lower down and kind of is like this. Well, we need another graph when you talk about the ethics of decision-making and advanced planning or advanced directives for the person with dementia. Because if I'm making an advanced plan or advanced directive now, in anticipation, for example, of having an accident that leaves me in a persistent vegetative state, I'm unconscious, and the plans I have now can fairly easily apply to the post-unconscious person. If I articulate them clearly in my directive. Whereas the person with dementia is a different kind of patient or person or individual. If I make a plan now for when I become post-demented or post-dementia, I'm post-dementia. That person post-dementia is a conscious person living their lives who may have different views about the views that I have now in anticipation of that. So planning, rather than directives, in my view, is something much more important there, because you need something that's much more fluid and can be adapted much more easily to the person the way they are now. So if you like, a narrative view of planning is something that the literature talks about. So, so visually, I would say we need another graph for the person with dementia about advanced planning. And I suppose in general that does raise a question for me about the AIIHPC documents that I've seen earlier, different presentations, which I've really enjoyed, and that is that they're light on the ethics, the ethics dimension of them in their presentation. I presume there's more of it in practice. But one other final thing I'd say about this morning that I picked up on as well from an ethical perspective that I think is really, really important, and Adrian mentioned it perhaps at the end of his presentation, I think. The person with dementia is somebody who cares back. They can care back. They are not just cared for. They are alive agents, individuals, human beings who are still our mothers and our fathers and our brothers and our sisters. And we benefit from living with them. We benefit, we learn, we live again our relationship with them even if it's 2 days beforehand, the thank you, if it's the holding hands, if it's the singing songs, if it's the dancing, which we would never do, except we have somebody who has dementia who will dance and sing with us. So they are a gift to us. And if we constantly see their loss of independence as a loss, instead of the gift that their interdependence gives us as people living in a community, then I think we're always wrong-footed when we approach the problems of trying to care for them and so on.
Can I come back to reinforce the advanced care planning? What we have been trying to do is a patient preference questionnaire. What sort of person are you? Rather than, can we have your views on X, Y, and Z? It's, are you the sort of person who likes? And I think that is an easier way.
Yes.
And it can include, and we've had it from people who said, for goodness sake, don't ask my husband about anything, because he's absolutely useless. And when he's upset, he's even more useless. But my daughter would be able to give a very clear view for you. And I think, it can be a very positive way of actually making it just, how are you and what are you, which gives a much more open view and doesn't restrict you so much.
And I think that opens the way, those kinds of conversations and that way of looking at advanced planning raises different research questions than the advanced directive approach, so.
Just to add a tiny bit to that, I'm better at English and Welsh law than I am at what you've just passed in your parliament, so I do apologise. But in the English and Welsh Capacity Act, advance refusals are legally binding, but they have to be specific, they have to be valid, they have to be applicable. And as a result of that, they're quite a limited tool, but I completely agree that advanced statements are much, much broader and enable a sensible and useful expression of your views. To some degree, being a bit on the English side, I often actually share with patients that, to some degree, when we're talking about it in advance, it's a bit like cricket in a way. If you're dying, then actually the request is to go a bit easy, chaps, and don't overdo it. And I think that kind of statement can be very helpful. The difficulty is that those statements have no legal force, which is fine because actually we know that the healthy do not choose the same way as the sick, and we know from multiple examples that whatever we've said early on or before turns out to be not quite or often not at all the view of people who retain capacity when an illness has come about. But having said all that, an advanced statement must absolutely have considerable moral force. You can't just say, well, they said this in 2016 and now it's November. Actually, we just disregard that. They must carry a significant moral force. And I think, therefore, that discussion, and I think your model, David, of discussion about preferences and things like that, it's a really good way to get into it, actually. Can be a great help. And finally, for care homes, at a time when people have lost capacity, or in fact, at a time when people retain capacity, we developed a set of questions about what people would like with different scenarios, because people are going around doing do not resuscitate forms, and that's fine, but fortunately or unfortunately, however you like it, people do not often suddenly die of a cardiac arrest in a care home. In fact, what they do is fall over, break their hip, they get a pneumonia, they get a stroke, they stop eating and drinking, and the questions are what you do with each of those scenarios. And we used those scenarios as exemplars to ask generally the carers, but sometimes it could be the patients, what they would want in those circumstances. And carers actually found that very, very helpful. Now, there was a trick question in the middle of it, because you went through pneumonia, dehydration, antibiotics, treatments and things like that. And we also added in broken hip, because actually, in those circumstances, whatever's in an advance refusal, actually the route to analgesia may well simply be a repair of that hip. And an unrepaired hip for 2-3 months is just 2-3 months of acute suffering. And I think, we would then think there was an unanticipated need. But that kind of discussion about the stems which you might think about when there is a deterioration, thus seeking to avoid hospital admission, for example, actually was quite very popular with carers in particular, who just thought that was really helpful.
Very good.
Can I just add something on advanced care planning? And it's echoing a little bit about what Joan said. And I kind of want to think into the future, maybe in 10 or 15 years' time, and maybe we'll just be able to talk about care planning and not have to use the word advanced, because I think at the moment that people are really scared of talking and doing advanced care planning, and yet in their practice they often talk about, when they're care planning, what people might like, what they prefer, and if we could, there's a risk that we can actually disenfranchise staff because we're looking at it as a specialist area, and yet many staff are doing it as it is. So that's one point. I think we need to encourage staff to, what I do know from what I've read on research is that staff maybe are not good about recording the discussions that they have had that often come up in informal opportunities that don't come from when they're doing the formal assessment, and that's what we need to encourage more, the recording of the care planning discussions that may be related to values and preferences in relation to future treatment.
I mean, moving on from advanced care planning, or does anybody have anything else to say on it? I mean, I suppose one of the things that struck me about the discussion about, even when we were talking about it, is whom would have the discussion, and and what location, or what at what stage of care. We do a certain amount of it, I suppose, within the memory clinic setting, but it's very superficial, and it's not really on with regards, the palliative end. It's more with the legal, enduring power of attorneys and things like that. So I don't know what thoughts were on the practicality of looking at primary care for doing this and taking this on.
You'll get me on my hobby horse in a moment. Not care. You want to watch out. You won't go home. I remember going to see a lady near Maidstone in a care home, and she spent most of the day crying out, I want to go to Tunbridge. And I asked the staff in the home what was wrong with her, and they said, oh, she's got cataracts and she's deaf. And I said, what else do you know anything else about her? She said, yeah, she can't hear. And all they knew was that she was blind and deaf. And I said, well, why has she wanted to go to Tunbridge? And said, we just don't know. Now, it was pretty actually simple to find out that, in fact, she had grown up in Tunbridge. That's where her parents were, and that's where her parents still were in her mind at that moment. And I used to say to people, when I go into a dementia nursing home, I really hope that people know I was an old age psychiatrist.
So I'm just going to follow you on that. I mean, I'm coming from a slightly different perspective, because I think that I suppose palliative care and dementia is really the intersection really of palliative care and dementia care. And to my mind, I mean, I'm coming from a kind of dementia end of things rather than the palliative care end of things. So I think there's a lot needs to be done to elevate I think this whole area in terms of awareness. The comment was made back, I don't know whether the person who's dealing with her mother is still here, as an advocate, about dementia care and primary care. I mean, there is very little emphasis in terms of training, in terms of chronic disease management, or research on the whole area, advanced dementia, and I think for that reason, and palliative care in advanced dementia, and I think for that reason, people don't really know how to do it. The services aren't really established or set up to do that, certainly in this country. And I think what you showed was, in your area, it's probably still quite novel in the rest of the UK. And this is, so I think I think really I think what this meeting has done for me has really raised my consciousness and my awareness about the importance of this area. And I think that this group really should go out there and really create this space and emphasize the importance of this area for research, because it's crying out for research, and the research needs to be done. I mean, I'd say, what are the research questions? I mean, I think that this is such an important area. I think you need to establish the key research questions, and then obviously the methodology is I think is challenging. It is challenging, and I think you do have to adapt your designs from many different areas to actually to be able to look at this question. I think that there is a huge lack of awareness among people like myself as a professional in terms of about palliative care and palliation. I mean, I was struggling, as I said today, about the concept, and I was one of the people who was I'm reluctant to jump in and talk about palliative care when I'm dealing with patients in the memory clinic, and I'm trying to emphasize brain health and mindfulness and maybe not looking too far back and too far forward. And the next thing, to introduce the concept of palliative care, which was in my head. Perhaps I had it misconstructed. And that's why I think there needs to be a lot of awareness raising about this intersecting area. I think it's only unless we develop the research questions, develop the awareness, bring the evidence to the fore, that we're never going to be able to change policy and practice. We're not going to be able to get primary care, I think, involved or secondary care involved in a meaningful way unless we really develop the space. So as I say, I found this really, I wasn't really sure what was going to happen today, but I found this really very, very informative for me. And I think, what I've seen today and heard today, and certainly what I've seen certainly in your practice, I think it has changed my perspectives. But I think people want to go away from this today. I think saying, you're going to create this group, this interdisciplinary group, are going to really claim this space, make it their own, and really define the research questions, develop the evidence, and that can be qualitative or quantitative, and then I think can make a big difference.
I think David will say something and I've said something, but there's a number of terms. There's specialist palliative, in England anyway, there's specialist palliative care, there's palliative care, and there's supportive care. And some specialist palliative care consultants have claimed that nobody else does palliative care, that everyone else does supportive care. And we made a very, very strong claim that that was untrue, and that in fact palliative care is palliative care. It doesn't matter really who does it, it's what the patient needs and what the patient thinks they're getting. So actually there are concepts of supportive care, there is concepts of palliative care and palliation, and then there's also specialist palliative care, which is I guess what dementia specialists like you and me don't do. But having said that, that's all about the issue of collaboration. It's all about who does it. Because what we certainly cannot and must not do is suddenly say, aha, this one needs palliative care, we've got to refer everybody to the hospice. So there is that sort of interplay, there's that co-education, there's that learning together, vicarious learning and development. And I suppose perhaps for dementia in particular, but also for some of the other neurological diseases, it's about being aware of that and building a competent network that can hold and support those people. Primary care is part of that, although the number of patients that a GP is going to be looking after with motor neuron disease is very small. The number of patients on any GP list with dementia will be perhaps 10 or so, so they are small numbers. So we're asking a fair amount of them to be really specialists and excellent at that. Big challenges, but it's about building that network. David?
I think I sometimes cynically think that supportive care was thought up so that people wouldn't say palliative. It was, having a new name, but it was a little bit like having the special clinic instead of the STD clinic. Everyone knew what it was because but it was a different name would make it all easier. And I think I look at it a bit like diabetic care, that a lot of GPs, a lot of general physicians will look after the vast majority of diabetic patients, but there will be some who need specialist diabetic care. And the diabetologist will need to see that 5, 10, 20% to have that extra special care. And the specialist palliative care will not see everyone who looks a bit dicky, which tends to be the thing if people are not careful, but everyone should be doing palliative care with the advice, support of specialists for particularly difficult, or to help with education, to help everyone raise up. And I think you do specialist dementia palliative care.
the palliative care
sometimes
people who visited us have said that's what, by the way, that's what you're doing, which is very nice of them, but
And there is an overlap, and there'll be some areas that somebody else will do that care. It might be rehabilitation for some neurological diseases in some areas. We'll have the specialist care, but as long as someone is looking at all these issues is what's important.
But is there still a little bit of confusion? I mean, is it very clear exactly what we're talking about in terms of palliative care and dementia? I mean, just listening to the two of you, now you're coming from slightly different perspectives in terms of NMD and dementia, what you do. I mean, why can't a GP, if they be trained up to deliver, it's a specialized, it's disease management. Is that not supportive or palliative type interventions rather than active or curative interventions? So this is what I'm trying to learn today.
If I could come in there, there's actually a national competency framework for palliative care that's out there since 2014, and it tiers the palliative care. So there's a generalist palliative care approach that every doctor should approach, every healthcare professional should have under their belt. Above that, then, there are generalists with a special interest in, and above that again, then, are the specialist palliative care consultants.
Are you referring to cancer, or what are you referring to? Just everything, so dementia?
Everything, life-limiting illnesses, yeah.
If there is in as much as there is a difference, I'm just thinking aloud now, but probably the big difference is that in people dying with cancer, they're not opiate naive. They've already often been analgesed for a while, and actually they have a much bigger requirement for analgesia. And in a sense, what happens in palliative care of renal failure and dementia and people dying with frailty in particular is that they do seem to be much more sensitive to medication. And actually the amounts you use will therefore be less. Certainly less in renal failure because morphine doesn't get excreted by the kidneys if you've got renal failure. And in dementia, Victor Pace, who developed a similar sort of service for people in nursing homes in St Christopher's district, he was actually starting with 1 milligram of morphine or more, just increasing slowly and finding that a milligram or two was often enough because patients are, one, new to the stuff, and also they're more sensitive to it. So it's about trying to get it right. And if you just pop on a fentanyl patch, that could be really quite harmful actually. So, you want to try and get the dose right while not giving so little that the patient actually has extra days of suffering and pain.
Absolutely. I mean, fentanyl is a whacking dose of morphine equivalent. That's actually jumping way up the scale as it is. And there's evidence out there to say paracetamol actually is the first line. And I suppose our cancer patients that we experience have multi-organ failure by nature. They're dehydrated. Their requirements for opiates may well be quite low depending on what the actual underlying issue actually is. And in terms of when do palliative care get involved, I think that's a very good point. I mean, with the cancer trajectories, it's somewhat more predictable. With the non-cancer populations, it's less predictable. It's palliative care for all, and early palliative care helps people live longer, but we cannot possibly see everybody at the earlier stages of their chronic diseases. I think King's College in London are starting to do, or they're in the process of doing, quite an extensive piece of research on input of specialist palliative care at specific transition points within chronic illnesses and looking at the cost effectiveness of that. So the likes of Parkinson's disease, motor neurone disease, MS and dementia, specialist palliative care involvement at particular points in those trajectories, and then discharge from the service and re-engagement again at another point. And that's probably the way things are going to go.
Yeah, and I think it's a very interesting discussion, but it's mainly clinical. And I suppose what we're trying to focus on is some of the research aspects. And probably the research aspect here is an effective community model of palliative care that might suit the Irish system, or how we would go, what aspects we'd adopt from the Oxley, from what you're doing, what would fit within our system, what would be resourced within our system.
You've got your own Irish one now. 2 posters at the back, so you want
Yeah.
to and that's really great.
Yeah.
And just something that strikes me is that I was really struck by your point about what are the questions, because I think if we stopped worrying about how we'd methodologically do it, or maybe for a moment paused and stopped worrying about the ethics committee, like I would look at a situation like that where you say we've got a number of really good models of what's happening at the moment. We want to understand what's actually happening in there. We want to distill that knowledge. I would look at that and say what you want is a cross-case analysis where you identify the core principles and practices that are happening in each site, map across them to look at the commonalities, look at the differences, and build almost a taxonomy of that model, what's happening.
Yeah.
And that's not randomized control trials, that's not large-scale powered studies. It's about actually using research to understand what is happening. It is the process model from the MRC. So if the question is, there's so many disparate forms of practice going on, and our question is, at its heart, what is palliative care and dementia, palliative care and MND? The type of research we need to be doing is quite conceptual and needs to be saying, well, let's map this. And we've done it in respite care for intellectual disabilities. There's so many models that we've actually done a systematic review to simply map the concepts that are evident when you say you're doing respite care. And that lets you build a model of practice. And then you can say, well, okay, if these are the key principles, can we evaluate their impact? Can we explore their prevalence? Can we explore their qualitative experience? But it is that idea of almost stepping back from what we think is the type of research we should be doing, and instead saying, how do we best answer these unanswered questions?
Mm-hmm.
I think the cost of the model and the cost effectiveness is key.
Yeah. And you can't measure cost effectiveness unless you can describe your model, and you can't describe your model till you've systematically studied it.
Okay, very good. I mean, I suppose some of the other. Do you want to say? Oh.
Palliative care physician. In order, I serve the acute hospital as well as the inpatient unit and the community, and we would regularly get patients with dementia referred. And it strikes me, and when I'm trying to inform my own consultation, we're capturing the wrong information. And we need to, in my view, take it right back there. When a patient is admitted to the acute setting in particular, they have a label of dementia, you have no idea of the degree of their cognitive impairment and their performance status pre-admission. That's nowhere to be found in their clinical notes. We have no idea of their personhood, anything about them. So it's almost like we need to train staff in a different way to capture the relevant information so that then a discussion about ceiling of care can begin. Because it's such a big umbrella diagnosis, and within that there are so many different domains to be considered. And I think specialist palliative care do have a role with the interventions in David's model of, you know, an intervention and then a discharge off the books, and that's in practice certainly what we're doing in this region. Oftentimes as an advocate and to facilitate discussions about ceiling of care. But I think we need to, if we were to research something, it might be how to formulate documentation so we're capturing the right information.
And I think if you looked at a project like that, piece of research like that, what you might end up with is a framework that could be replicated in multiple sites to pool information to then ask other types of questions, so that you end up with a standard evaluation framework or a standard assessment framework that you can pool anonymized data, so you minimize some of the data protection issues. But again, you begin to build a picture of what we're actually doing, and then you can begin to look at, well, what are the variations in what we're doing and what causes them and what triggers those, again, to develop your picture of what's going on. So instead of constantly focusing on some of those more, well, what works, start asking first, what are we doing? Is it working? And why is it working? And to build the research that way.
Absolutely, and I suppose it's a two-way street. Our communication from the acute hospital is usually equally as poor as some of the communication. And I suppose HICWA have kind of stepped in with regards to nursing home transfers in particular and trying to streamline some of that communication. But certainly it's a wide spectrum. Yeah, when you know, some are better than others. I mean, with regards to some of the other topics that were touched on, technology was one of the interesting ones that I think Joe had mentioned, and how we could adapt technology, look at technology. There was mention of a patient register, or for people who are interested, and I don't know what thoughts were on that concept, or whether people had anything they wanted to add on.
Technology is great. It actually solves problems. It enables people to stay at home rather than being put in care. So it's sometimes just by giving families that confidence that someone's okay. There's wonderful gizmos like things that actually ring up the daughter whenever you boil the kettle, and send a text message. And that's really helpful, because then the daughter has the reassurance that life is continuing as normal, and there's a sort of an alert system. The patient should consent to that, but on the other hand, it can be very, very useful. Actually, at the end of the day, however, the most effective treatment that we have for dementia is 75 to 80 kilograms QDS of person. And it's that individual personal care which really makes a difference. As with so much of the rest of care of the dying, actually you can technologise as much as you want, but actually people, and good people who are actually doing a good job, are absolutely essential to good outcomes. And that's something we just have to bear in mind, actually.
But that isn't seen to be as valuable, as you pointed out about the medication. I think that's why we need to raise awareness about this. I mean, that's so important. The chronic disease management, the palliative care, the advanced care, for these people in the community as well. That's so important, and we need to emphasise that. And it gets us out. I mean, I think the cost effectiveness is crucial. If you can show that those timely interventions with specialist palliative care, it makes a difference in terms of quality of life and saves money at the end of the day. I mean, it's going to be a slam dunk, and that's what you have to do.
And I think just to come back to that issue of methods and research, I think technology has a huge role to play in streamlining systems of recording within hospital and health settings. We've just finished a project where we were looking at KPIs for A&E departments and how do you assess management of practice in those settings. And we were going into hospitals and finding that the files were kept in boxes in a building 10 miles away and couldn't be accessed electronically. If you want to maximise your learning from practice, you have to have good recording of practice that you can access and learn from. And if you're still recording things in cardexes and patient files and don't have a centralised IT system that allows you to pull down that data and use it, you're not going to get anywhere. You're still not going to know what is happening.
This is where I think there's role for ethnographers and sociologists and historians and so on, because I think that I really believe strongly in public awareness campaigns in education for the general public, but also for health professionals and healthcare staff and allied staff in general. But Ireland, we are in a unique kind of situation where for a long time nuns and the Legion of Mary did a lot of the heavy lifting of our caring responsibilities. This is in my lifetime. Perhaps some of you missed out on that. But we're now changing into something very different, and there's gender to consider. Women are doing different things now instead of doing a lot of the heavy lifting the way they've done in the past. So care as a concept, the nursing profession as a gendered profession, and other allied professions as gendered professions. Look around the room, folks. Not up here now, just the room in general. So these kinds of issues, to thread through, to figure them out for the Irish context, how we respond, given our particular history and the history of our professions as well, is something that I think we have to get to grips with, and I certainly need other inputs for that.
Thanks very much. I don't know if there are any final burning comments, but I think that's a nice place to wrap up the discussion. And I think it's really, really important that we acknowledge the fantastic day and the phenomenal efforts of Suzanne and Siobhan and Karen in hosting the day and putting it together. I think it's been really, really informative. I think there's been a huge cross-pollination of ideas and discussions, which hopefully all of us will be able to take forward.
So I just wanted to thank you all for sticking with us. And again, I personally want to say, I mean, Siobhan Fox and Carl Fitzgerald have done all the work that's made this day run so smoothly. So thank you again, and I'm sure you're going to enjoy your weekend after the week we've had of getting everything ready. Just to please fill out your evaluation forms, particularly, you know, if there's any last thoughts you have or anything that we could have captured, or even things about this day or if, to improve it. The Irish Research Council, as I said, did fund it, and they would like to know, is it worthwhile, and what did you like and what didn't you like for future workshops. And also to let you know that we have recorded all the talks, so as well as the slides, we'll have access to the recording. So we're going to email you the link, and they'll be put up on websites. And I'd like to actually particularly acknowledge the All Ireland Institute of Hospice and Palliative Care, who have actually funded the recording of it, and it's a great resource for people who couldn't be here today as well. So we'll send you the link, and it'll be up on websites as well. Okay, so again, thanks very much everyone for your participation.